on the dais. So here I am to speak regarding subdural hematomas. So let me bring a case scenario here. So a 68-year-old male who underwent post-aortic valve replacement, he was on anticoagulation with warfarin 5 milligrams. He presented with sudden onset headache, vomitings, difficulty in walking since 3 days duration. On examination was little drowsy with generalized weakness. There was no focal neurological deficits on clinical examination. The initial CT scan revealed bilateral hyper and hypodense collections, both frontoparietal and also temporal regions. So it is an acute and chronic subdural hematoma bilaterally. There is no midline shift here. So the decision was taken to go for a burr-hole evacuation of the subdural hematoma. 2 burr holes placed on either side, frontal and parietal, and the component of subdural hematomas was evacuated. Post-operatively, this is the image CT scan with little residual acute component on the right parieto-occipital zone. So subdural hematomas, they're classified as acute, subacute, and chronic. So basing on the timeline and their appearance on CT scan. Acute 1 to 3 days, which is very hyperdense on CT. Subacute from 3rd day to 3 weeks roughly, which is isodense compared to the brain parenchyma. Chronic subdural hematomas, more than 3 weeks duration. They are hypodense. So we find the shape of the subdural hematomas goes lenticular. What are the causes? So traumatic acute subdural hematomas. Trauma causing a parenchymal laceration and there is accumulation of blood in and around the lobar zone, predominantly frontal and temporal regions. And second cause is there is tearing of bridging vessels by sudden acceleration and deceleration of the head. Violent head motion can cause. Nowadays, as previously mentioned, many elderly patients have been using these antiplatelet drugs, anticoagulants, novel anticoagulant drugs. So an atrophied brain with a meninges, there is a small space which is easily vulnerable to accumulation of bleed, even with very trivial falls or even with any violent head motion, causing a subdural hematoma. So primary brain damage may be less severe when there is a torn bridge vessel. So here we can find a lucid interval with later rapid deterioration, as we see in EDH. So what are the indications? Indications for surgery in acute subdural hematomas. When the hematoma is thick, when thickness is more than 10 millimeters with a midline shift more than 5 millimeters, it should be evacuated regardless of the GCS, even when the patient is fully conscious. A subdural hematoma with less than 10 millimeters thickness and if the midline shift is less than 5 mm should undergo surgical evacuation only if a GCS drops by more than 2 points from the duration of injury to the time of admission, if there is any asymmetry in the pupils, whenever the pupils are fixed and dilated, these 2 conditions we have to consider for surgery. Thirdly, if GCS is less than 9, but the subdural hematoma thickness is less, patients can go for intracranial pressure monitoring. So meeting the above criteria, as soon as possible, the subdural hematoma needs to be evacuated. Here in acute setup, acute subdural hematomas, craniotomy with or without a bone flap removal and a duroplasty is ideal. How is the prognosis? Prognosis depends on initial GCS score, the age, and the associated underlying brain damage. So early surgery definitely improves the outcome. So as you see this mortality is very high with GCS around 3. Less than 6, we almost 50% there is mortality rate. Functional outcome is also very poor in these scenarios. So, seizure prophylaxis in subdural hematomas. So, is it really indicated? Yes, it may be safe. If the patient present to you with a subdural hematomas, a prophylactic anti-epileptic drug, if it has started, within 1 week, if there is no seizure, we can stop using the drug. If a late seizure occurs with or without use of prior anti-epileptic medications, a long-term therapy may be required. Associated hyponatremias, usually with subdural hematomas, need to be managed carefully. Hyponatremia in a setting of majority in trauma settings in neurosurgery, we come across two conditions. One is a cerebral salt wasting, other is syndrome of inappropriate ADH. Both are same in laboratory, values appear the same, except that there is difference in the total body volume. Cerebral salt wasting, there is loss of both sodium along with water, which can be managed with isotonic saline. If at all it is not getting controlled with isotonic saline, hypotonic saline can be used, but it may increase the output also. So hydration is the key here. Syndrome of inappropriate ADH, SIADH. Here, restriction of fluids is the key, because the patient can be euvolemic or hypervolemic. So restriction of fluids with addition of salt, if still version, 3% NS can be used. Correction must not be more than 12 milliequivalents liters per liter per day. Acute setups. And evacuation of subdural hematoma can reverse the hyponatremia. Coming to chronic subdural hematomas. Chronic subdural hematomas, as the term is coined, pachymeningitis hemorrhagica by Virchow. So they usually occur in the elderly, average age around more than 63 years. Head trauma is identified in less than 50%, but other risk factors like alcohol abuse, seizures, CSF shunts, patient on coagulopathies, and patient with risk of falls, hemiplegia and previous strokes. So these are associated risk factors for chronic subdural hematomas. What is the pathophysiology? So blood within the subdural space, it evokes an inflammatory response, and within days, fibroblasts reach the site, invading the clot and forming a neomembrane, which has two surfaces, the inner cortical and outer dural surface. Within this, slowly there is ingrowth of neocapillaries, there is enzymatic fibrinolysis of the clot, liquefaction of the clot, and there is accumulation of a fluid, motor oily fluid there. So the course is determined a balance between plasma effusion and or rebleeding from the neomembranes. And this is the graphic representation where there is an acute subdural hematoma collection there, and inflammatory cascade which made a gelatinous semi-solid mass to accumulate within the neomembranes. So this lands the key for treatment of subdural hematomas. We intervene in this vicious cycle at two sites. One is surgical drainage. The other thing is a minimally invasive procedures which have come up now. So middle meningeal artery embolization is really doing wonders, is preventing recurrence in subdural hematomas. So let us go into site to see what are the minimal invasive techniques available. So the aim is to reduce the recurrence with minimal invasiveness, because elderly patients who are surgically not good candidates, we can opt for these minimally invasive procedures. Middle meningeal artery embolization, tristle craniostomy with SEPS, subdural evacuating port system, can be done bedside. Endoscopic assisted evacuation using an endoscope. A mini craniotomy for draining a localized subdural collection. Ultrasound guided drainage is also emerging recently. Middle meningeal artery embolization, ideal for chronic subdural hematomas, high risk surgical candidates where surgery cannot be done under local anesthesia, in a suit. So significantly reduces the risk, widely adopted, and is guideline supported. So that is a zone where once the middle meningeal artery is embolized, so we can, there is no much recurrence or collection at that site. So usually following any chronic SDH evacuation, if there is a recurrence, we can go for this procedure. Twist-drill craniostomy with SEPS. This is a bedside procedure used to, a tiny twist drill is used in elderly patients with minimally invasive under local anesthesia. You can put a twist drill and the port is connected hermetically to a three-way cannula and you can drain the fluid. So this is a system which can be arranged at the bedside. Endoscopic assisted, when there are a lot of adhesions, a mini craniotomy can be done and endoscopically guided. The visualization is good and the entire clot can be evacuated. The recurrence is low and the equipment is really good at utilizing this in a minimally invasive manner. Mini craniotomy with drainage, where full craniotomy is not advised, we have to, it is a localized collection, we can use it with using a neuronavigation also, where you can irrigate and drain the clot. Ultrasound guided drainage is emerging now, so where currently in experimental stage, but suitable for high risk frail patients, least invasive options, it is still under evaluation. So comparing the methods, middle meningeal artery embolization has very low recurrence. It is good. SEPS has a moderate recurrence, but simple bedside technique using a twist drill. Endoscopic evacuation, we have a better visualization. It is luxury. And mini craniotomy is a precise suitable for organized clots. Ultrasound guided drainage is also least invasive. It is upcoming and still need phase 1 trials. In summary, a shift towards invasive methods for subdural hematoma, lesser invasive methods is among which middle meningeal artery embolization is the game changer really. It is preventing the recurrence. And bedside procedures also reduce the hospital burden and stay. Endoscopic and ultrasound guidance, drainage of the subdural hematoma is evolving now. But whatsoever, personalized treatment selection is the key. So we have to go individualistically. Patients on anticoagulants or antiplatelets, take care, utilize your resources well for the best of the patient. Thank you. Time is brain. That's very important.